Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Alexander Saw. Dr. Saw completed his fellowship in minimally invasive procedures and revision hip and knee replacement at Rush Medical Center in Chicago. And Dr. Saw was born here in Fremont at Washington Hospital. He graduated from Haverford College in Pennsylvania and from medical school at Thomas Jefferson Medical College. Dr. Saw then completed his orthopedic residency at Massachusetts General Hospital and Brigham and Women's Hospital in the Harvard Orthopedic Program.
And good afternoon. Thank you all for coming here today. And on behalf of myself and Dr. Dearborn, we want to thank you for taking the time, and we look forward to talking to you about knee pain, how to diagnose it, and the various treatment options. So the overview of the talk today will be, I'm going to talk to you a little bit about the knee basics, the anatomy and function of the knee. Hopefully that will give us a better understanding of the possible sources of pain in the knee. And we'll talk about both acute and chronic injuries, how to diagnose the differences between the two. I'll tell you about what we as physicians look for when we examine a patient in the clinic, or the various imaging studies we may use in addition. Then I'll talk about some of the non-operative treatment modalities that are available, and if those fail, various surgical options and the pros and cons of each. Dr. Dearborn will then talk about knee replacement, which is one of those surgical options, and also briefly about our Center for Joint Replacement. So first, some knee basics. The general anatomy of the knee, being that it's a joint, means that there are two bones which move against each other. So the top bone would be the femur or thigh bone, and that bone moves against the shin or tibia bone. And the kneecap is a small bone, which you can see here, which is in your extensor mechanism. Essentially what it does is it gives your ability to straighten the leg more power and more force when you do so. So those are the three main bones in the knee joint. The fibula is another leg bone, but that's outside of the knee joint. Because it's a joint and because those two bones move against each other, there's cartilage on the ends of the bones, the white stuff on the end of a chicken bone. And that cartilage is represented in these pictures as these white surfaces, or sort of a yellowish surface here. And that's what gives you cushioning and what gives you painless motion in any joint in your body. Next would be ligaments, and ligaments are structures which connect bones to other bones. There are the collateral ligaments on the sides of the knee, which you see here, and there are the cruciate ligaments which cross, and hence how they get their name. And those are commonly injured in sports athletes, for example, the ACL or PCL, which are injured. In addition, not pictured here are the muscles and tendons around the knee, which give you obviously function and strength. So to give another representation of the knee, this would be a picture of your knee. So the front and the back, okay, and then under the skin, there's obviously vessels, veins, and arteries, and things like that which can get damaged. So when you bruise your knee, when you hit your knee, that's what causes bleeding under the skin and causes bruises. But also under the knee, you can see that there are various muscles shown in the red and the ligaments and tendons as well. So any of these things can be a potential source for pain in the knee. If you go a little deeper, again, you can see that there are more tendons and ligaments. The yellow would be nerves around the leg and the knee, and again, vessels, arteries, and veins in that area. And as you go deeper, again, are the ligaments holding the knee joint together, as well as the cartilage on the ends of the bone. So that's essentially what makes up the knee. The function of the knee, as you know, is obviously it's weight bearing, but in addition it allows you to bend the knee. So that's where the cartilage comes into play. In this side view of the knee, you can see that that cartilage extends both on the end of the bone and the back of that femur bone, which allows that thigh bone to roll onto the shin bone. You can see the kneecap there, and what happens is, again, it gives you more strength and force out of your extensor mechanism, but it also has to glide within that knee joint, which is why there is cartilage under the kneecap and in the corresponding portion of the thigh bone. This would represent a tendon, and here are other ligaments again in the knee. So what's important to know is that the knee feels 3 to 5 times your body weight with normal activities. It can go up as high as 7 times or greater with jumping or jogging activities. So that gives you a good example of why the knee hurts when you're weight bearing on it, or why the pain can continue when you're weight bearing on it. Simply because, again, the knee sees 5 times your body weight. And this will be important later, because for every 1 pound of weight or extra weight you may be carrying, that's potentially 5 pounds of extra force on your knee. Now we'll talk about acute versus chronic injuries. Acute injuries of the knee begin after an identifiable cause or is of recent onset. Chronic knee pain, on the other hand, persists beyond that expected healing phase, or it fails to resolve. There are basically 6 categories of acute knee pain. You can have fractures, which is injury to the bone. You can have injuries to the muscles or tendons, which would be sprains or strains. The ligaments can get injured, again, causing knee sprains or dislocations potentially. You have injury to that cartilage or to the underlying bone, or you can have simply contusions, either of the skin and the soft tissue or even of the bone. So returning to anatomy, injuries by anatomy, underneath that skin, again, are the muscles and tendons. So if muscle tears, like in that picture on the left, that can cause acute knee pain. Or if the tendons get irritated, it can become inflamed and become a tendinitis, both common sources of knee pain. Below that are the ligaments, again, the soft tissues which connect one bone to the other. Those can get sprained. They can even rupture, and you can even have knee dislocations. Underneath that is the cartilage. The cartilage in the knee, again, is the white portion at the end of the bone, but there's also C-shaped pieces of cartilage in the knee, the meniscus. You've probably heard of people who have had meniscal surgery with arthroscopy. That would be represented in this picture on the left. These are the various types of tears you can have of that cartilage, and that can happen in an acute fashion, causing knee pain and swelling. And lastly, of course, are injuries to the bone or fractures. Those can come in both severe types like this, or less severe with hairline fractures or other injuries which can cause knee pain. Chronic knee pain is most commonly caused by something like arthritis, and osteoarthritis or wear and tear arthritis is by far the most common. Osteoarthritis is simply the loss of cartilage in that picture on the right. So that white protective layer is being broken down and worn down, and underneath is exposed bone. So with the weight bearing and the forces across the knee, or with motion, that exposed bone now rubs against other exposed bone, causing pain. And that pain won't get better. The natural history of arthritis pain is that there are good days and bad days, but overall, the good days probably aren't quite as good as they used to be, and the bad days are a little worse than they used to be. So that would be osteoarthritis, or wear and tear arthritis. Inflammatory arthritis is another type of arthritis which can also affect the knee or other joints. And examples of that would be rheumatoid arthritis, or ankylosing spondylitis, or psoriatic arthritis. Less common, but definitely prevalent. Avascular necrosis is where part of the bone loses its blood supply and actually dies. It's not very common in the knee, but it can occur and cause chronic pain. Avascular necrosis is more common in the shoulder or in the hip areas. Very rare are things like tumors or infection of the knee as a source of chronic pain. They're quite rare, but something that physicians don't want to overlook. And lastly are overuse syndromes. Irritation of the bursa or tendons or muscles around the knee can cause chronic pain. So just a little bit more about knee arthritis, because by far that's the most common type of chronic knee pain. Arthritis, again, is simply the loss of cartilage at the end of the bone. So that underlying bone is exposed, and that causes pain, swelling, stiffness, and sometimes catching or locking. Again, it's generally the result of wear and tear. It can result from prior trauma many years ago or from inflammatory type arthritis. The main issue with loss of cartilage is that we can't regrow cartilage yet. We can't transplant cartilage, and we'll talk about the ways to treat end-stage arthritis later. Next, we'll talk about diagnosis. So when someone with a painful knee comes into the clinic, the things that we look for as physicians, first we look at the gait or how someone's walking. That can give us a lot of information about what's hurting a patient and what the problem may be. In addition, we'll look at the outside of the knee, such as rashes, lesions, or bruising. Next would be something like effusion, like this lower picture on the right, showing swelling of the knee. These things help give us a clue of what may be the cause of the acute or chronic pain. We'll also assess the knee range of motion, the stability of the knee to test those ligaments, the strength of the knee, and any areas of tenderness. So truly, physical examination is the key to a timely and accurate diagnosis of knee pain. Imaging studies really are used to confirm that diagnosis found by physical examination. X-ray is probably the first imaging study you'll have, and that is a great first-line study of bone. There are some markers of knee swelling and ligament injuries which can be seen, but in general, it looks at the bone of the knee. A CAT scan evaluates that bone in even more detail. However, for the first-time injured knee or the chronic knee, again, CT scan is typically one of the later studies used and often isn't required. The other downside of a CT scan is that there's a lot of radiation exposure because it's many X-rays combined into one. An MRI is another study which we can use, and that looks at soft tissues. It's so sensitive that sometimes, unfortunately, it can pick up changes in the anatomy which may not actually be the source of your pain, but it does give us a good look of the anatomy of the knee. And the other thing about an MRI is it does not give you the same radiation exposure as something like a CT scan. But all these things are possible imaging studies which might be ordered to evaluate knee pain. So now we'll talk about those non-operative treatments. So this algorithm is actually from the American Academy of Orthopedic Surgeons, and this came out just about a year and a half ago. And this is the guideline recommended by our national committee in terms of how to treat knee pain, both non-operatively and then operatively if necessary. So first, for non-operative treatments, we'll focus on this top portion of the algorithm. So the first thing to do for anyone who has knee pain is PRICE, or RICE. And what that stands for is the P is to protect that area from further injury. So if that knee is hurting or injured, you can use a splint or an elastic bandage or a cane or something just to protect it from further injury. The next thing is rest, to promote tissue healing, to avoid activities that promote more pain or injury to that area. Icing is very useful. It helps with swelling and pain. It can also slow any potential bleeding into that knee. And we recommend repeating it every 2 to 3 hours for the first 48 hours, about 15 minutes at a time. The C stands for compression. Again, an elastic bandage or a neoprene sleeve can help in terms of symptom control, but also controlling the swelling of that knee. And lastly is elevation. Elevating that limb above the level of your heart will help reduce the swelling and help that acute pain go away. After that, the first non-surgical treatment option would be an over-the-counter medication, non-steroidal anti-inflammatory drugs, or NSAIDs. These are Motrins, ibuprofens, Advils, things of that nature. This is usually the first-line medication used for pain, and especially arthritis pain. It reduces swelling and warmth in the area. The thing you have to watch for is it can irritate the GI tract, so it's best taken with food, but you want to take it regularly if you can to get the best anti-inflammatory effect. It does have an effect on platelets. It is reversible, but you have to have caution if you're on blood thinners, things like Plavix or Coumadin, because it could potentially thin your blood more. In addition, anti-inflammatory medications are cleared by the kidney, so if you have predisposing kidney disease, you may want to watch how this affects that function. Other over-the-counter medications include aspirin, which is another potent anti-inflammatory. It also can affect platelets, however, so you have to be cautious in that regard. And acetaminophen, or Tylenol, is another good pain reliever, but you have to know that it does not reduce inflammation. So typically, pain with the knee is a soft tissue injury related to inflammation. That's why we often recommend NSAIDs first. Tylenol can be taken in addition to the NSAIDs. They don't interact, but just know that Tylenol is strictly a mild pain reliever, not an anti-inflammatory. The maximum dosage you can take is 4,000 milligrams in 24 hours, and you want to have caution if you have liver impairment. So unlike the NSAIDs, acetaminophen is cleared through the liver. If those fail, there are prescription medications. So there are prescription strength doses of NSAIDs. This would be things like naproxen or oxyprozin, Mobic, diclofenac, or Celebrex. There are many out there. There's no science to say that one is better than the other, but some people definitely respond better with one than the other. So it will take a little bit of experimentation, but they all basically work in very similar fashions. There are other medications such as Enbrel or cortisone or Imuran, but these types of medications are typically for the inflammatory arthritis, so rheumatoid arthritis or other things. so less common in the general population. Lastly, narcotics are sometimes used to help with knee pain, especially chronic knee pain, but remember that these also do not reduce inflammation. In addition, their primary function is to mask pain. So one concern is that taking narcotics can mask pain when you're injuring yourself, and so you don't know you're doing it, but also that if you require narcotics, that means your knee pain is significant enough that it probably warrants examination by a physician and may even require some sort of surgical intervention. Many people ask about glucosamine chondroitin sulfate. It's a natural compound found in healthy cartilage. It's a building block of cartilage. It's available as a food product, so it's not approved by the FDA because, again, it's classified as a diet supplement. So there's no evidence to suggest that it works or doesn't work. People take it, and some people say it works for them. Worst case scenario, it may be an out-of-pocket expense. You want to have caution if you have an allergy to shellfish or iodine. One of my mentors made a great analogy, which I'll remember forever. Because glucosamine is a building block of cartilage, his analogy was that it's very similar to a bald man who eats hair. Basically, just because you eat that product doesn't make a lot of sense that it's going to go exactly where you need it and it's going to stay there. But again, if it works for you, there's very little loss except for perhaps some financial cost. After the medications, there is activity modification. So if you're having knee pain, doing things to change activities in your daily life, like walking instead of running, or using an elliptical or swimming rather than jogging or the treadmill, or avoiding stairs or using a walking stick, all these things help offload that painful knee. So certainly that can help with symptoms while you're healing. Again, because the knee joint feels 3 to 5 times your body weight, any weight loss that can be achieved certainly can help, both in the short term and the long term. The body mass index is one way to measure height versus weight, and this scale is available, and essentially it can give you an idea of whether you stand overweight or if you're in the normal weight class. Physical therapy can help. Range of motion and flexibility exercises of the knee have been suggested to be helpful with knee pain. Leg strengthening has been proven in the literature to help improve symptoms, and exercise definitely helps. It's been shown actually that the exercise and physical therapy is best with an organized program both at home and at an organized facility. But it's important to know that the benefits are often lost within 6 months of stopping that program. So it's something you should continue to maintain that strength in your leg. Injections are another mode of treatment for knee pain. Cortisone injections can help acute pain. It helps with swelling and discomfort. It can last anywhere from a few days to weeks to months. The idea is that the lidocaine is like Novocaine, a numbing medicine, which you get at the dentist, and a small amount of steroid, which helps with inflammation. So it's an anti-inflammatory provided locally into the knee. There's a very rare and small risk of infection, and some people will have a flare reaction after the injection. But in general, they're well tolerated and do provide temporary relief. But it's important to know that this does not reverse the process of arthritis or cartilage tears or other injuries. It helps with the symptoms, but it's not curative. Viscosupplementation or hyaluronic acid injections are another method of injecting a substance into the knee, which has some mild anti-inflammatory and mild analgesic effects. The idea is that it restores the lubrication to the knee and gives more fluid into the knee. And again, this can help people for anywhere from days to weeks to months. It really varies from person to person. There are some adverse reactions. Again, you can have some swelling or pain several hours after the injection, and very rarely infection. If you're allergic to eggs or chicken, it's not suggested that you take this injection. The studies have suggested that this hyaluronic injection is basically about as useful as taking over-the-counter anti-inflammatory medications. So if you can't take those NSAIDs, then this is definitely something that's worth trying. Some other some other additional guidelines given by that Orthopedic Academy are knee braces. Knee braces can help offload the worn or painful portions of the knee. They are bulky, and the Academy's recommendation is somewhat mixed. They're equivocal in terms of whether it helps or not. Similarly, acupuncture and those hyaluronic acid injections, their stance is somewhat equivocal whether it makes an improvement or not. They actually recommend against glucosamine chondroitin sulfate just because of the lack of information. Not that it's harmful, but just there's a lack of data suggesting that it does positive things. They recommend against heel wedges or other shoe inserts to try to address knee pain. And they recommend against things like a unispacer or these interpositional devices which some people use to insert into the knee to help with isolated arthritis. And now we'll talk about surgical options. So once those non-surgical options have failed, if nothing else is helping, then you go to the bottom portion of this algorithm. And really there are 4 surgical options for knee pain. The first is arthroscopy, which we'll talk about and when it's most useful. The next is tibial osteotomy. And the third and fourth are knee replacement. The third is a partial knee replacement, meaning a more limited or focused knee replacement. And then the full knee replacement, again, is that fourth option. So arthroscopy is using a small camera, which is about the size of a pen, to enter into the knee so you can look into the joint. Basically, you can evaluate the ends of the bone, those C-shaped pieces of menisci with that camera. So you can do various treatment options for various diseases, which I'll talk about next. But this is a picture of what it will look like. This is the end of the femur bone, and this is the shin bone here, and this C-shaped piece of cartilage, which you see, that's the meniscus, and that's often where there are tears. And you can evaluate the thickness of the cartilage, and this is an example of the cruciate ligament. So you can get a close inspection of the knee. With arthroscopy, it's really best for treatment of things like meniscal tears like this. You can see how this has a tear here, and this is what it looks like with a camera. So an arthroscopy can go in and can clean that area and debride that tear, sort of like the frayed edge of a rug. Arthroscopy is also good for removing loose bodies in the knee, and it can also be used to debride any frayed cartilage at the end of the femur or on the tibial bone or under the patella. But again, it's really limited to those type of treatments. It is an outpatient procedure. It's well tolerated. There are a few risks. But again, remember that arthroscopy, it debrides or removes tissue. It doesn't put tissue back. It doesn't restore cartilage that's missing. 15% of people undergoing arthroscopy may progress to more significant arthritic changes. And this is an arthroscopy picture of knee arthritis. You can see the white is the normal cartilage, and these yellow patches are where the bone has now been exposed because the cartilage is worn. The next treatment option on that algorithm is osteotomy. And osteotomy is essentially a controlled fracture of the limb. So when you develop arthritis, then you get malalignment of that limb. It can either be knock-kneed, like this picture here, or you can develop bowing of the leg. Because that leg is out of alignment, the forces from the hip to the ankle go through the more worn areas of the knee, and it causes constant pain. So realigning that limb can restore the balance to that knee joint. So that osteotomy can occur at the end of the thigh bone, like in this picture here, or it can occur on the top of the shin bone. So a wedge of bone is either removed or added to that area in order to realign that limb. The advantages are that it preserves the native bone. There's no limitations in terms of function or what you can do after that surgery, and you always can have a joint replacement later. The major disadvantages, and the reason that this treatment option is really falling out of favor, is because it's a very involved procedure, it's very painful, it's a prolonged recovery, there's significant scarring of the tissues, and there's always risks that the bone may not heal, because again, it is a controlled fracture. So the next treatment option would be replacement. And so in this schematic here, this is the end of that thigh bone again, and the white is the cartilage. This would be a representation of diffuse arthritis. So the patches of cartilage loss have extended throughout the knee. The left side shows that that cartilage loss is isolated to one part of the knee, and that's where partial knee replacement works best. It's sort of like a mini knee replacement for only one portion of that knee. It can be used on the inside of the knee only, the outside of the knee only, or under the kneecap only. What's important is that you need early diagnosis in order to be a candidate for this procedure before that arthritis is spread to the rest of the knee, because then you're no longer a candidate for this procedure. The potential benefits of a partial knee replacement compared to a full knee replacement is that it's a less invasive procedure, it's bone conserving, there's less blood loss, it's ligament preserving, there's better range of motion, there's a faster recovery, and the knee feels more like itself because you preserve those ligaments in the knee. Partial knee replacement has been shown to be durable for 10 to 15 years, and if at some point it needs to be converted to a total knee replacement, it can be done quite easily. So partial knee replacements are applicable to maybe 10 to 15% of the arthritic knee population, but in those who are candidates, it works very well. This is an example of a patellofemoral replacement And it looks a little bit different because really what you're doing is you're resurfacing only the kneecap area. So some people, about 10% of patients, will have pain just under the kneecap. And so by resurfacing the kneecap, you get rid of the bone rubbing on bone, like in this picture. And this metal portion goes on the other side of the kneecap so that as the knee moves, the patella glides metal on plastic and no longer causes pain. And this procedure has also been shown to restore excellent function for those who have isolated arthritis in the kneecap. This is a brief video which will give you an idea of what partial knee replacement is. Again, this is the thigh bone on top and shin bone on bottom. Those are the various ligaments and cartilage in the knee. So when you have damage to one portion of the knee, in this case the inside of the knee, that damaged cartilage, there's bone rubbing on bone, and that's what causes pain there. So if this person fails non-operative treatment and requires a surgery, a small incision is made over that area. That area is exposed, and only that inner portion of the knee is addressed. So the meniscus is removed because you don't need that once you have a partial or a full knee replacement. And a small portion of bone, a few millimeters, is removed from the ends of the bone. Cement is applied and a partial knee replacement component is then placed. This replaces the exposed areas of bone so that now you will have metal rubbing on plastic. And again, this won't hurt. But what you can see is that the other side of the knee, the kneecap area, all that is left alone. So in someone who's a candidate for this, it can provide excellent restoration of function and relief of pain. And this is an example of a partial knee replacement, a patient I just happened to do a couple weeks ago. And so this was her x-ray 2 years ago, where she had pain on the inside of her knee. She had multiple surgeries. She had her cartilage removed after a skiing accident. 1 year later, the joint space is narrowing, and prior to surgery, you can see it's bone rubbing on bone, and that's what hurts. This is an x-ray of that partial knee replacement. So it's metal on plastic on metal, which resurfaces that area. So there's no exposed bone on exposed bone. That's the side view there. And this is her less than 2 weeks after surgery. She's regained full motion at under 2 weeks. And this is her walking. And she states this is the first time she's walked in many years without pain. So in the appropriate patient, again, this can have excellent results. So as an overview, with this algorithm, the first thing to do to treat either acute or chronic pain is price. Protect, rest, ice, compress, and elevate. After that, you also want to try activity modification, exercise, or weight loss. The anti-inflammatories and over-the-counter medications are very helpful. If those fail, knee injections are available. If those non-operative treatments fail, the next thing to do would be make sure you're evaluated for your knee pain, and arthroscopy is useful for those specific diagnoses like we talked about, loose bodies or small cartilage tears. Osteotomy, again, is rarely indicated. Partial knee replacement, we just talked about, is useful for arthritis limited to one portion of the knee. And the fourth surgical option is total knee replacement, which I'll turn over to Dr. Dearborn to talk to you more about. Thank you very much.
Dr. Dearborn completed his undergraduate degrees at Stanford University and medical school at UCSF. Dr. Dearborn did his orthopedic residency at UCSF and his fellowship in total joint replacement at Massachusetts General Hospital and Harvard Medical School. Dr. Dearborn is the medical director for the Washington Center for Joint Replacement.
Hi, it's great to see you all here. It's nice to have a relatively full room, and hopefully you learned a lot during the first half of the presentation. Hopefully you appreciated how great my partner is and how excited I am to have him back home where he belongs, where he grew up here in Fremont. So Alex is a very, very important part of our program. We couldn't do much moving forward without him, so I am in his debt, and he gave a great presentation. So moving forward, my charge is to talk about total knee replacement. Alex did an excellent job covering the evaluation and treatment of knee pain in general, and talked about the treatment options short of total knee replacement, and I'll kind of finish it out, and then I'll spend the last 15 minutes giving you an update on the Center for Joint Replacement program in general, because I know a lot of you are very interested in that. You see the new building that's going up, and we'll talk a little bit about that. But moving forward, what is a total knee replacement? Well, it's it's kind of like the partial that he showed you, but more. A total knee is a resurfacing operation of the knee, but we're resurfacing the entire end of the femur and the entire top of the tibia, unlike the partial knee replacement that Dr. Saw showed you. So the joint surfaces are entirely replaced with metal caps, and then a plastic insert is attached to the tibial component, which acts as your artificial cartilage, and that's diagrammed here on the bottom. When is a total knee necessary? Well, that's pretty easy, and that's when nothing else is going to do the job. So a total knee is the end of the line for patients who have osteoarthritis of the knee. In some cases, the alignment is too far off for a partial knee replacement to be enough, or for an osteotomy to be enough to solve the problem, or at least delay a knee replacement. Sometimes the wear involves more than one compartment of the knee. Dr. Saw talked about wear on the inner side or the outer side, or wear between the kneecap and the femur, where a patellofemoral replacement might be appropriate. If the wear involves more than one compartment, then a total knee replacement becomes the only viable surgical option. And in some cases, a prior reconstructive operation has been done, which has now failed, and in the vast majority of those cases, a total knee replacement is the best procedure to continue forward. So here's some cases where, to illustrate the points I just made, obviously this first one, the alignment is way off on this poor lady, and so you're not going to be able to do anything short of a total knee replacement to treat this. A more mild case, patient with wear on the inner side of the knee that you see right here, but her patella looks like that, so that's wear in 2 out of the 3 compartments, and so that's best treated with a total knee replacement. Here's a case on the bottom, a heavy attorney where a partial knee replacement was done, but unfortunately the partial knee replacement was put in a little bit malaligned. The tibial component is tilted where it shouldn't be, and now it's loose. So in that sort of a situation, to resolve that problem, you need to take it out and put in a total knee replacement. And then here's another situation, a postman who had this partial knee replacement done somewhere else, and his patellofemoral joint that you see right here is badly worn, and so in that case he's only got one compartment that's involved, but he's already had a failed partial, so you'd have to resolve that problem with a total knee replacement. Of course, the knee implants used for total knee replacement have evolved. On the top are some pictures that I have of older implant designs showing kind of the progression. So there's been a progression since the very late 1960s in this country doing total knee replacement. So we're seeing much more modern appearing implants. In some cases, we're even using uncemented implants to do knee replacement. The techniques have evolved as well, but essentially we're able to take the knee that you see on your left and pretty consistently put in the knee implants that you see toward the right and restore alignment, restore range of motion, and restore function. So it's a pretty reliable operation. And you can even take severe cases like that earlier one I showed you and reconstruct it and get the joint correctly aligned and get the patients walking around feeling much, much better than they did before surgery. As the implants have evolved, we've also seen evolution in techniques, as you might expect. Around 1970, Dr. John Insull in New York is really considered the father of knee replacement in this country. He really trained in the process of training residents and later training fellows, put total knee replacement on the map of the United States. Many other people have come as well to add to Dr. Insull's legacy, but he's considered the founding father. So from 1970 till about the year 2000, there wasn't much change in the technique. But in 2000, Dr. Luke Vaughn, who was actually an orthopedic oncology physician down in San Diego, who had been doing a lot of knee replacements in his practice in order to treat tumors around the knee, thought, you know, you should be able to do a total knee without flipping the kneecap over during the operation. And so he worked with one of the implant companies to develop some instruments to make that more feasible. And so he's the guy that I really credit with the concept of doing a total knee without flipping the kneecap out of the way, which turns out to be a huge advantage. And then in the advent, with the advent of less invasive techniques to do partial knee replacements, Dr. Fred Tria in New Jersey and Dr. Tom Kuhn, he was at the time in Ohio, developed some instruments with one of the implant companies to do a total knee replacement through the same type of incision that you heard Dr. Saw talk about doing partial knee replacements through. So Dr. Tree and Dr. Kuhn get most of the credit on that in terms of the instrumentation. And in 2004, I was fortunate enough to be able to bring the less invasive knee replacement operation to the Bay Area. February of 2004 was our first case. So in general, just to tell you about the results of total knee replacement, just across the board, not with a less invasive technique necessarily. It's about a 12-week recovery period after the operation. Most patients are able to walk and bike and swim, generally pain-free. Probably 5% of patients will still have some residual pain that will limit them in some ways. In terms of the longevity of the operation, 80 to 90% of the implants are generally working well at 20 years. So that means 10 to 20% aren't, and 10 to 20% may have been redone. So it has a pretty good longevity. And of those implants that are still working well after 20 years, we expect them to go potentially 30 years. So it's not a 10-year solution for knee arthritis. There's about 700,000 total knees done last year in the US, and that's certainly on the rise. The rate of knee replacement is going up, paralleling the United States obesity curve, actually. So given the fact that a total knee replacement works well, I've been asked by many people, why change the operation? Why change what is already working? And the answer is that knee replacement takes a long time to get over. As I mentioned, it's 3 months, and even at 3 months, you're not all the way there with a traditional total knee. You're probably 90% of the way there. It may be a year before you're really completely over the operation, especially the first few weeks are very difficult. And our patients are demanding a much more rapid return to activities. So if we can get our patients back to work at 6 weeks instead of 3 months, that's a big advantage. And so that's where these less invasive techniques have become quite popular. I would say that the term MIS, which stands for minimally invasive surgery, is a bit of a misnomer because I think a total knee replacement has a lot of invasion. It's not a minimally invasive procedure. We're opening up the knee joint. We call that a capsulotomy. That's the same sort of thing that you're doing with a total knee, although we're not cutting as much. We're still making the same bone cuts to put the implants in, so we think that a total knee is probably going to hurt about the same whether you do it through a small incision or a larger incision. The implants are identical and the fixation's identical, so to call a less invasive version of this operation minimally invasive is probably a misnomer. So I like the term less invasive rather than minimally invasive. The key to making this operation work is something that Dr. Vaughn was talking about in 2000, not flipping the patella when you do the operation. So if you don't have to flip the patella over, then that means you don't have to cut up as far into the quadricep tendon to mobilize it, which means that when the physical therapist tells you to bend your knee, your quadricep tendon is not going to hurt so much because it hasn't been cut and it hasn't been twisted 180 degrees during the operation. And our data shows that, in fact, that's the case, that the quadricep, because it's less traumatized, causes less problems early after a knee replacement when you've done it with a less invasive technique. So I've already hinted a little bit at the effects of reducing the quadricep trauma. You have less quadricep-related pain, which makes sense. We're probably not going to see reductions in swelling because you're still doing the bone cuts, which is probably the thing that causes the knee to swell the most. We definitely see improved quadricep flexibility, which would result in better early flexion, which is what we've seen in our studies. Just comparing a less invasive versus a traditional total knee side by side, a traditional total knee is typically a much more lengthy incision, 8 to 12 inches in length. The typical less invasive technique is 3 to 5 inches, 3 inches in someone very small who needs a very small femoral component. We're not cutting the quadricep tendon when we do a less invasive technique. We're not twisting the quadricep muscle at all, and I'll show you a brief video of this so you can see what I'm talking about. And we're using much lower profile jigs during the operation to make all this possible. And the picture at the bottom shows 2 jigs that we use to align the femoral component, and the one here on the right is the one that is the traditional one that's got these long extension bars out on either side, and the one on the left is the cut down version. And you can imagine if you're working through a very small incision, you'd never be able to get these large side bars into the wound, and in fact those large side bars had no particular purpose. But the engineers put them in there because when they were making their instruments, they would see wide exposure in the operating room, so they never thought they'd be in the way. And so thinking about the knee operation differently has allowed the engineers to come up with much better instrumentation to allow us to do this operation less invasively. On the right is the typical skin incision for a less invasive total knee replacement, only slightly longer than with a partial knee replacement that Dr. Saw was showing you. On the left is a traditional knee replacement skin incision. This is the type of exposure that we're used to getting. We just push the kneecap off to the side. This is the patient's kneecap here. His is my thumb. And we're able to see the end of the femur to be able to attach our jigs. And next, I'll show you this video. There you go, it's better. So here we'll skip through this a little bit, but you can see that there's the skin incision from just above the kneecap to below the patella. There's not going to be any blood here, so you don't have to avert your eyes necessarily. We do a little bit of superficial dissection just so we can get everything in there. We're opening up the knee joint here to expose the joint itself. We do a little bit of elevation work to lift up the knee capsule so that we can see into the joint. So this is the inner side of the femur. This is the inner side of the tibia. And here we are taking out the fat pad on the back of the patella. And I'm just going to move us forward a little bit here. We cut the kneecap first so that helps us with our exposure. And there we are. We've pushed the kneecap off to the side. So the kneecap's sitting over here. And we can gain access to the end of the femur just fine. We can attach our cutting jig to the end of the femur just fine. You can see we're doing most of the work from the inner side of the knee. The patient's outer side of the knee is over here. So we're able to access the end of the femur fine through this technique. I'm just going to go a little bit more forward. We make our bone cuts. And then we're going to, in this particular operation, we did the tibia next. So we make the bone cut on the top of the tibia. Again, we're working more from the inner side of the knee rather than the outer side. So if you see a patient with this, with the incision from this operation, the incision is placed on the inner side just so we can get access this way. That's why the incision's not right up the center of the knee joint. So after we cut the tibia, we take out the tibial bone piece. And then we go back and we're going to finish the femur. We're going to attach some jigs to make some bone cuts here on the femur. And this is our finishing block that allows us to make the remaining bone cuts on the femur. And you can see this particular finishing block attaches right to the end of the bone. The device we used to use required pin fixation on either side of the femur, which would of course require that the kneecap be well out of the way to attach the jig. But you tell the engineers, hey, we'd like to be able to attach our cutting jig to the end of the bone, and they say, oh, okay, well, why didn't you tell us that before? We'll give you a jig that does that. And so then we can make our bone cuts without having to invert the patella. So here's the patella just pushed over to the side. You can see we have a very good view of the joint to do the bone work necessary. Okay, I'm just going to push this forward a little bit more here. So we're going to finish the femur. Got our box cut we do. So now you see the shape of the femur. It's been machined and prepared to be shaped just like the back of the implant we're going to use. We're preparing the top of the tibia to accept the implant. There's a keel on the particular implant that we're going to use in this case. And you see there's mallets and chisels and saws, and it's like a wood shop here. So you get the idea here. So the day after the operation, when the epidural anesthetic is being turned down, and you won't wonder why you're sore. But fortunately, the pain does go away. So here we've got all the bone surfaces prepared, and so then we're trialing the knee, and then we're going to cement the implants in place. So we've got our bone cement being mixed. So here we are cementing in the tibial component, and we clean up the extra cement. And then we cement the femoral component on, just pressurizing cement manually. See, it's a very manual operation. My thumbs are all over the place here. And so we put the femoral component on, and then we're going to put our liner in, and then we cement the patellar component on. We just plugged the peg holes on the back of the patella with the cement. We've got our implant on. And then we just let the cement harden. And once the cement's hard, we close up the knee joint, and I think that's my PA, Keith Jeffrey, tying suture there. And there we are at the end. I think on this video we actually have the guy get up and walk. Yeah, there you go. So this is actually an elderly internist, and this is 18 hours after the operation. So he's able to do a straight leg raise because we didn't twist his quadricep during the operation. And there's Vicky Feng, one of our excellent physical therapists, getting this gentleman up. And he's going to show off and say, look, I can walk on this thing, and here he is cruising along. You see he's got his walker. He's just had an operation. Okay, this guy's in his early 80s, and he's going to cruise down the hallway there. So you kind of get the idea. This is a bigger operation than a partial, but it's still a reliable operation that works well. So let me finish out what I was going to talk about with my presentation, and then we'll have substantial time for question and answer. Just looking at the results of this, we've been doing this operation, as I mentioned, from February of 2004 until now. So given the volume of total knee replacements we do, you can imagine we've done a lot. And I looked up our data actually from last night just to see how many we had done at this point, and we're over the 4,000 mark with this technique between myself and Dr. Saw. We do a lot of bilateral replacements where we replace both knees at once, and we have over 1,600 knees where they were part of a bilateral operation. Our average age is just under 70. You can see there's quite a wide range there. Just slightly over half of our patients are women, and you can see our average body weight. The knee score is a measurement that we do to measure preoperative and postoperative knee function. In the first 6 months of this project, so from February to August of 2004, we looked at how long the operations were taking and some other criteria that we looked at, and that was 260 knees in the first 6 months. Our average surgery time actually went up. We were doing total knees in about 50 minutes. It went up to 61 when we started using this technique. So the operation took us longer, but in the process of trying to improve our efficiency more, now we average about 45 minutes. So we're actually faster than we were with the older technique. And we're not rushing, but we have a tourniquet inflated during the operation, so there's really no points for going slow. You don't want to rush, you want to be accurate, but the longer that tourniquet's inflated, the longer it's going to take to get blood flow and back to the muscles and the bones, and that's not a good thing for the leg to be avascular. So we want to be accurate and quick. Our typical single knee patients in this series were in approximately 2 days, 3 days for the bilateral knees, which is about the way it is now. 92% of the patients in that first 6 months were discharged directly home, so not a very large number going to rehab facilities. Our number is even higher now. Our average flexion at the time of discharge was 110 degrees in that series. It had been 89 degrees before going to the less invasive technique. So at 2 days, we were bending 21 degrees better than we were bending at typically about 3 days with the traditional technique. So we did see that earlier flexion improvement, which we attributed to less quadricep trauma. The average time to get rid of the cane in that series was 7 days for patients having a single knee replacement. So it was pretty impressive. And so we said after that first 6 months, we're not going back to doing the traditional technique because it just seemed like it was a significant improvement. So in conclusion, on the exposure effect of the less invasive operation, it seems to us that avoiding patellar reversion and the quad dissection that everting the patella requires allows our quadricep mechanics not to be so negatively affected. And I mentioned that you get an earlier straight leg raise, earlier ambulation without a cane, a better motion. We think that effect probably lasts about 3 months. Once you get out a year, I don't think that the less invasive patients are functioning any better than the traditional technique patients. Although for the patients where I've done one type on one side and a different technique on the other side, the patients often still prefer the one where we did the less invasive technique. They may just be remembering back, but I don't think that there's much functional difference. So I don't think that there's a big long-term benefit, although there may be fewer adhesion cases in the less invasive group, but I don't have enough numbers to say that. A lot of people ask me about the advertisements they've seen for special knee replacements for women, and I guess you have to first ask the question, are men and women different? Well, their knees certainly are. And the way that men and women's knees are different are primarily related to aspect ratios. It turns out that the front of a woman's femur sticks out a little bit less than the front of a man's femur. So when you put in your implant, you want to be able to take that into account. The angle that the kneecap tracks at is slightly different in a woman. And most importantly, the end of the female femur is a little narrower than the end of a male femur, given the same anterior-posterior dimension. So basically, their aspect ratio is different. Women are more slender on the end of their femur compared to a man's femur. Men's femurs tend to be a little bit boxier. So you have to ask yourself, so what? How does that affect knee replacement? Well, when we have off-the-shelf implants, it matters. It's nice to have some options. So one of the implant companies specifically designed a total knee femoral component to fit the female femur. The original knee replacements were designed to fit the average femur, which meant kind of the average between a male and a female, which means that if you're a very narrow female, the implant might be too wide for you, or if you're a particularly wide male, you may not get the coverage that you need with the implant. So a lot of those differences had been ignored until Zimmer came up with their gender-specific implant. We don't want our implants overhanging. Overhang is very rarely a good thing. It's not good in this picture. So these are some comparison pictures between Zimmer's standard knee replacement implant on the left and then the gender-specific version on the right. On top shows that the anterior flange, we call it, is narrower for the gender femur compared to the male femur. The blue line is the male and the pink line is the female. From the side, the standard implant is thicker, the gender implant is thinner in the front, and then the quadricep angle in the standard implant has a different angle than in the female, because women's hips tend to be a little wider compared to their stance width, and so women benefit from having a slightly different angle there on the implant. A lot of other patients have asked me about computer navigation, so I thought I'd put just a couple slides on that here in this presentation to close us out. Computer navigation is essentially using a computer to help align knee implants, and you think that sounds like that might be a good thing because the computers are smart. Unfortunately, we know that data in is about as good as the data that comes out. So we have to decide when to use it. And we use computer navigation here when our usual reliable methods are not feasible. And so you can tell that my bias is toward using our usual reliable methods, which are putting rods up inside the bones. So that's the technique that we're used to and that everybody's trained to do. The femoral component alignment, as you saw on that video, is determined by a rod that goes up the shaft of the femur and then a cutting block that's attached to that rod. The tibial cut is based on an alignment guide that we attach to the front of the tibia. You can also put one down inside the tibia to get a good look at that as well. So that's the usual technique. And you can't use that in cases like this. This is a gentleman who had a femur fracture when he was a child and it was fixed, and then he had a growth abnormality. So you see his femur's curved and he's got a plate in here. So to put a rod up inside the bone and get useful information from that is not going to be helpful. This is his knee from the side. The end of the femur is cocked way backward compared to where it should be. You're not going to be able to get good information. So I used a computer to navigate this knee. This is a OR setup for a computer-navigated knee, and there's these devices that are attached to the bones to tell the computer where the bones are, and then the computer tells you essentially where to cut. This is a useful technique, as I said, when you can't put rods up inside. But again, you've got to have an intelligent surgeon driving the operation. You don't want to turn the operation over to the computer. So unfortunately, it's used a lot for marketing. I see ads for joint replacement programs around the Bay Area that say, we use computer navigation. The implication is that it's more accurate, that it doesn't slow things down during the operation. That is not true. The implication is that it's somehow better for the patient. There's no data to show that. And that it turns a good surgeon into a great surgeon. Again, no data to show that. So let me just spend the last few minutes talking about the Center for Joint Replacement program. Many of you may already know about it, so just indulge me. This will be a review. But we founded the Center for Joint Replacement here in Fremont in 1999, and it was really to equip our passion for doing joint replacement surgery and to providing an outstanding environment for what turns out to be a really highly needed operation. We drafted the mission statement right at the beginning. which was to provide state-of-the-art joint replacement care in a highly efficient yet personal way. And that's the mission statement that we hold to. Looking back, the keys to the success of this program, first of all, was partnering with Washington Hospital, which was a very friendly environment to allow us to do what we needed to do to equip the nurses and the therapists to take very good care of patients. We created a core group of nurses and therapists. We basically had to humble ourselves and say, okay, how can we work well together? And that's not something that's taught in residency training programs. We created essentially a hospital within a hospital to control all the processes and to create our own newer, better culture within that program, which is an important step. And then we pursued excellence in every way. And we did that, first of all, by having a very, very narrow focus, which allowed way more attention to detail. That allowed us to refine our surgical techniques. And with the volume of work that we were doing, it allowed us to reduce our process variation, which is very important, which helps you, of course, minimize complications. It creates a continuum of care when you have case after case after case, and the nurses and the therapists are used to dealing with patients with these particular problems. And that coordination allows us to have a very narrow focus from the start of the process to the finish. So in our office, we only see patients who need joint replacements or revisions of failed ones. Our operating rooms, our laminar flow operating rooms, all we're doing in there is joint replacement surgery. We have our specialized joint replacement unit where we only take care of joint replacement patients. Our home therapy group that we use, most of their volume is from this program. Our outpatient therapy places that we partner with become very specialized as well from taking care of patient after patient with hip and knee replacement. And so all along the way, people can say, this is all we do. And it's true. It's not just lip service. The results of having an integrated approach like that, you can imagine it's going to be growth, because that doesn't exist in medicine across the country. And it really doesn't exist in the Bay Area other than this program in terms of taking care of elective patients. We've had a lot of growth by word of mouth from patients. Eventually, those patients' physicians start to send us patients because their patient was so happy, and doctors want to have happy patients, so they start to refer other patients. And then as a result of that, we start getting patients coming from outside the normal drawing area of the hospital. So this is our growth curve, just in case you're curious. 2010 there on your far right, here we are. This is the total. And this is where we started when I got here in 1997. So that growth has been largely patient word of mouth, driven by the pursuit of excellence of the program. This is our demographics. The Tri-City area is this light blue triangle. So this is where our patients are coming from. You can see that larger than our blue triangle from the Tri-City area is the patients from the peninsula. This is East Bay other than the Tri-City area, and you can see we've got a broad distribution of patients. The Monterey Peninsula is this triangle right here. Every week we do 3 or 4 from the Monterey Peninsula. It's just really been interesting to see how far patients are willing to travel to get this level of joint replacement care. So when you're growing like we are and you start to do this kind of high volume, it allows us to continue to improve our efficiency, which is helpful for fostering relationships between us and the hospital, between the hospital and vendors. You can get some economies of scale, which helps you with your cost containment. It allows us to accumulate a tremendous amount of data, which allows us to audit our processes in real time. So we can see, okay, well, we did this 20 times this week. How did it change the outcome, and should we make a change again or not? And it's allowed us to advance the field of joint replacement through outcomes research, which we're presenting at various meetings. As I mentioned, the outcome studies we're doing come largely from our massive database of patients at this point. Presentations have been done from the nursing side, from the physical therapy side. Generally, I am presenting on results of various implants and techniques. Dr. Saw is doing the same. We've got, as I mentioned, lots of publications and presentations around the country. More importantly, though, how are we doing with our patient care? If you look at the objective data, you'd have to say we're doing pretty well. This last year, there's a company called PRC, which is a a surveying company based in Omaha, Nebraska, and they survey patients after discharge to get feedback about their experience. And they survey, that particular company surveys about 250 hospitals every year, and they give a rating to the hospital based on what the patients say. So this is patient satisfaction data, and our program's the #1 orthopedic unit in the country. Okay, and that's the 3rd year in a row. 3 years out of the last 5, I believe. The reason patients are saying that is because they feel like they come first on the unit. From the environment, they're treated first by the personnel. The quality of care they receive makes them feel like they are the #1 priority. And the attitude of the staff, I think, certainly contributes to that as well. This hospital is known for its patient-first ethic, and so what you see on the joint replacement unit is just it's just a sort of a microcosm of the mission of the hospital at large. And so they're doing this in other programs as well, but I don't spend much time elsewhere, so I only know about CJR. In terms of the environment, we've always thought it was important to have our patients in a separate building to quarantine the patients and facilitate team building. Having private rooms, the patients certainly appreciate. We do a lot with group physical therapy, which creates a healing, encouraging environment to have patients interacting with other ones. We like doing meals as groups. Our personnel on the unit are specialists. The nurses only work on that unit. The physical therapists on that take care of our patients only work on that unit. So they're specialists. And the therapists we've had here, we've had very, very few turnover. Elisa Curry, who was here when I started, is still here, and Vicki Feng, who we brought on with the program several years ago, is her right-hand person, and Joffrey that I see sitting back there, started with us a few years ago, and he's not going anywhere. So we have good retention of our excellent employees. And we also have tremendous volunteers, many of whom have been through the program, and they help on the unit, and they encourage the patients. And for patients to see people that have gone through the program want to come back and volunteer, I think it speaks volumes. We talked about the general quality of the care, and a lot of that's driven by protocols, which helps the nurses streamline things. We've got the high volume of cases, which also allows streamlining. The staff can focus on building relationships with the patients rather than worrying about, okay, what do I do day 1 after hip replacement? They already know that because they've been doing it for years, so they can focus on getting to know the patients, which I think make the patients feel much more appreciated. And there's some minor comforts like, we let them shower on the unit, we don't staple their wounds. The attitude on the unit is truly a wellness concept. These patients are not sick, they just have a worn out joint and they're coming in to get it fixed. So the tone on the unit is positive, and the approach is more sort of concierge, but also a lot of loving grace, which is very important. These patients are in pain, and to treat patients that are in pain, that might be frustrated at times, requires a lot of grace. And that's an important piece of what we do day to day on the unit. I want to give you just one other objective accolade. There's a website, healthgrades.com. They're actually a big agency now. Healthgrades.com rates hospitals based on procedures. They rate doctors based on procedures that are done. And those ratings are based on readmissions for complications related to the operation. And Healthgrades has access to all of this data because it's public data when it's from Medicare patients. So all the Medicare data from around the country is available to public agencies to look up. And so Healthgrades rates rates hospitals based on certain procedures. So Healthgrades you can look up on the internet yourself, and Healthgrades gives 5 stars as a maximal rating, and Washington Hospital Center for Joint Replacement has had 5 stars for hip and knee replacement since 2002, and this last year we had the highest rating in California. So this is your #1 joint replacement program in California based on readmissions and complications. So that's good. Of course, occasionally we have complications. It doesn't mean we're going to have a 0, but this is invasive surgery, and occasionally there are going to be problems, but you can be confident if you're going to a place where it doesn't happen very often. So that's helpful information. So where are we at now? It's been 13 years since we founded the program. We're doing about approaching 1,400 joint replacements a year, which is a large number. We're serving many out-of-state patients, as I mentioned. We're pretty highly rated by reviewers. We're doing patients out of state every week. We're a teaching center. Where are we going? Where do we have left to go? Well, we have a long way to go. We have a new building, which is just about done. We should be in it in January or February of next year, which is going to house the inpatient unit as well as our outpatient office. Our surgical volume, I'm sure within 5 years, will be over 1,600 joint replacements a year, which ends up spreading the reputation because every patient we operate on goes out and tells a few, and so it just ends up growing. My goal is not to change our mission statement at all. We're here to take care of each patient, one patient at a time, and our great staff, as it expands, allows us to do that and hopefully continue to do it in a very high quality way as our objective ratings show. So changing gears back to knee pain, our general recommendations, and we're going to have some question and answer now, is that we tell patients to do their research, to read up on their condition, review who's out there and who's doing what, and pick the surgeon in the program carefully if you end up needing an operation. Higher volume certainly means fewer complications, and so we think it's important always to talk to doctors about how many they do. And many of you may be Kaiser patients, and that's certainly a question that you should be able to ask your doctor in the Kaiser system. And the surgeon should talk to you about what approach they're most comfortable with, et cetera, because you don't want to ask the surgeon to perform a procedure that they're not familiar with just because you read about it somewhere. So you want to do what the surgeon's most comfortable with. So with that, we'll go to some question and answer time. Dr. Saw, I'm sure, will come up here and join me. And we've got some people with roving microphones.
2 questions. Number 1, what's the rate of infection that you've experienced? And the number 2, it sounds like you use Zimmer as a manufacturer of the parts. How long have you been using them, and have they had any recalls?
All right, so let me, I'll repeat the question in case you didn't hear it. There were a couple questions. Number 1, there was a very good question about infection rates and then implant companies that we tend to go with and what their issues have been. Let me address the infection rate first. Our infection rate's about 0.2%, in that we're talking about deep infections. Superficial infections, redness of the wound and things like that, which can be managed with antibiotics and local measures. That's not considered a deep infection. And obviously deep and superficial infections can be related to diabetes and general cleanliness and things like that. A deep infection is bacteria that ends up in the joint. It can be introduced at the time of surgery, or it can end up in the joint from your bloodstream. And that's a serious matter, and especially the ones that are introduced at the time of surgery, because if you're in an institution that has a high infection rate, then that suggests that something about their operating rooms may not be as clean, their systems may not be as good there, maybe the surgery's taking a long time, so the wound's open a long time. So it's the deep infection rate that you want to track, and 0.2 is a very, very low rate. That doesn't mean it's 0, it's never 0. And I'll speak to the implant thing. Alex and I both are, at this point, we're using primarily Zimmer implants. Zimmer's a company in Warsaw, Indiana. We can use whatever we want. I'm not paid to use one company's implant or another company's implant. Personally, and Alex, you can talk about why you like Zimmer, but personally on the total knee side, Zimmer has been a very good company in terms of thinking forward. They're the ones who came up with the concept of doing something different for female femurs. No other company has done anything on that, even to date, since Zimmer released their gender-specific knee a few years ago. They also were the early company working with surgeons to develop instruments to do less invasive knee replacement. Most of the other companies have now followed suit, but Zimmer was, again, on the forefront of that. They've got very, very good plastic bearings. And so as a result, I think Zimmer last year was #1 in market share in the US. So a lot of other people think they're good too. They have not had FDA recalls of their implants. You'll see stuff in the news related to lots of different implant companies. I don't think there's been an FDA recall of anything since Sulzer's hip socket was recalled because of machine oil left on the back of it. But you'll see product advisories that come out. Zimmer has not had a recall of the knee implant that we use. Alex, do you have any other comment about implant company choice?
I would just add, I use Zimmer again for many of the same reasons that it's a very, the company is great in terms of working with surgeons, giving us what we need, and worldwide it's extremely commonly used and it has a great track record. So it performs well and it lasts a long time, and those are very important things. You may have seen on the internet or newspapers things with about the Depew or Johnson & Johnson hip. I'm sure a lot of people are nodding. That was one particular design, again, by a company we don't primarily use, we use rarely, and a specific bearing, which we also don't use. So that has not applied to the Zimmer product line.
Would you recommend the operation for a patient who has atrial fib, who is 80 years old, and what about blood clot?
So blood clots is a risk after orthopedic surgery or any surgery of the lower leg. We do various things to help minimize that chance, such as epidural anesthesia, which has been shown to reduce that chance by about 40%. Because we're able to get you up and walking the day of or the next day after surgery, that obviously decreases the stasis in that limb. We'll use compression socks and other things, and we will use some sort of prophylaxis, whether that's Coumadin or Lovenox or aspirin. So we do various things to help prevent clot, and clot does occur after joint replacement, but we're very careful to make sure that it doesn't happen. So the incidence is quite low with this program. In terms of atrial fibrillation or other comorbidities, we base a lot of that on the health of the patient and what their primary care physician may say. Obviously, we want you to leave the hospital better than when you come in. Knee and hip replacement is a major surgery, but because it's less time on the operating table, epidural anesthesia, fast recovery, in general, people do well. Atrial fibrillation is not a contraindication to joint replacement. We operate on people in atrial fibrillation all the time. People who are on Plavix for heart stents, Coumadin for atrial fibrillation, diabetes and other things. But obviously we want to make sure that that particular patient is in the best health that they can be in prior to undergoing the surgery.
Yes, I need hip replacement surgery, and my knee has been extremely painful, and I've had to wait a long time because of bureaucratic hassles and clinics and all that. And my doctor in San Francisco has refused to actually check out my knee properly. She's done a very sort of superficial kind of checkout, and I feel like I need an MRI on my knee because she keeps just referring me for hip only, and I need to do hip and knee, and also with an x-ray of about a year and a quarter ago, I was diagnosed with moderate degeneration in the lumbosacral joint, and I need to know, do I need to check my spine out before I do hip replacement, and also I need to still have a proper diagnosis of my knee. The initial x-ray showed that my knee was okay, just the bone to bone, that there was enough cartilage, but this was about a year and a quarter ago, and I think things have gotten worse since then. I've got the inside information. And my doctor, I'm having a really hard time. She's in San Francisco. She's just not cooperating with me regarding checking out my knee and referring me for an MRI. What do you think of all of those three joints?
I wanted to make an initial, everybody hear that? Kind of long question, but the theme that I got actually from listening to that was that the doctor-patient relationship is not what it should be. Okay, that's something we're trying to hit on here. If you're going to take a patient through a treatment course, a treatment algorithm, as Dr. Saw was talking about, it needs to be a dialogue. It needs to be a back and forth dialogue. So in medical school, we're taught, maybe we forget we're in residence, but in medical school, we're taught, listen to the patient, they're telling you the diagnosis. So, if the doctor's not listening, that's not a good thing. So, my general advice is you need to get, you might want to change doctors. Okay, I'm not doing that self-serving, but I'm not thinking that you're happy and that it sounds like the doctor-patient relationship is damaged. If you're going in and considering having hip replacement, you should know the status of your knee, because your knee may stand in the way of you rehabbing adequately from your hip. If your hip and knee are both arthritic, generally surgeons will do the hip first, but you need to know the status of the knee. And if an x-ray doesn't show the problem and the knee is bothering you as much or even more than the hip, An MRI scan would be a helpful study to show whether you have a torn meniscus or not, just like Dr. Saw was saying. I would also add that the lumbar spine is important because if you have a pinched nerve in your back, that can radiate down into the leg. It can mimic a knee problem. It can mimic a hip problem. And so that needs to be studied as well. And sometimes, and I'll take the hit for orthopedists in general, sometimes if our focus is hip and knee or hip, we ignore the other things wrongly. So sometimes it takes going and seeing a spine specialist to figure out, do I have a spine problem as well? And oftentimes that type of doctor called a physiatrist is a really good one, because a physiatrist is a physician who does non-operative back and neck and hip and knee treatment. And so sometimes starting out with someone who's not a surgeon is better.
Thank you.
Okay, we have a question here.
Can a person with osteoporosis do the surgery also?
Yes, many of our patients do have osteoporosis. Many of our patients are elderly and are on medications for osteoporosis. In general, they handle the implants and recover just as well as anyone else. Obviously, you want to be aware of it and take your calcium and vitamin D and other things, but osteoporosis, unless it's extreme, which is very rare, is not a contraindication to any of these surgeries.
Okay.
For bone-on-bone, is there something in the works, or is somebody working on some better technology that will make, I guess that would solve that problem without going through all the surgery?
It's difficult, similar to the slides I put on about osteotomy, where the weight-bearing line shifts. That's what happens as you wear down your arthritis. And so the problem is if you become bow-legged, which is the more common pattern of knee arthritis, that weight line has shifted to the inside of the knee. So if you try to inject something, let's say someone's invented an injectable cartilage or something to put in there, the problem is you haven't restored the alignment. And so the alignment and the weight bearing is still going to go through the inside of the knee, and it's going to wear off or damage whatever product you did put in. So unfortunately, that has not been designed yet or figured out yet.
Yeah, there is some work on doing cartilage regeneration, and you can read about that. You can Google it and things like that. Unfortunately, the type of cartilage that's growing with the regeneration technology that's currently out there is not normal cartilage. It's not the really resilient, what we call hyaline cartilage. It's more of a scar tissue type cartilage called fibrocartilage, which is not very durable. It's kind of like filling a pothole with sand. It's better than nothing, but over time it's not durable. It's not as durable as asphalt, so the sand spills out. Same kind of idea. And when we do get something that's growing hyaline cartilage, it's first going to be applied to patients who have a focal defect, children or teenagers or early adults who have a focal cartilage defect that if you treat, it won't become a big problem. But for the patient who has global bone-on-bone, at this point, we're nowhere near any solution other than what we're currently doing.
I just want to know if all the orthopedic surgeons doing the total knee replacement use the same material?
Is it the same material?
Yeah, so knee replacements in general it's titanium, it's cobalt chrome, it's a highly durable plastic. So there are some surfaces which people use which may or may not improve the wear characteristics, but in general it's metal, plastic, and metal.
So all of you, the orthopedic surgeon in total knee replacement, use the same material? Everybody of you, all of you?
The same material, not necessarily the same brand. There's lots of implant companies out there. The whole implant business is a multi-billion-dollar business, and there's 3 really big companies, and then there's a bunch of smaller ones. So lots of different brands. They essentially are all made out of the same materials, however.
Okay, one over here.
What are the best types of exercises you can do for your legs to help keep them strong, and then what's the worst kind you can do?
Best and worst is really, it's personal, it's what you can tolerate. Obviously, exercise in general helps keep the legs strong, but you don't want to do so much that you end up hurting yourself. In general, lower impact exercises like swimming or riding a bicycle or the elliptical machine is less pounding, less force on that knee compared to a treadmill or running or jogging. In addition, just when you're sitting down, you can do simple things like leg lifts or quad contractions or other things just to strengthen the muscles in that thigh, to strengthen the forces around the knee.
I was going to say another exercise we recommend for patients who specifically have knee arthritis and are worried that exercises are going to aggravate their knee is Dr. Saw already mentioned stationary bike is a good one, but another one is doing wall sits like you might do getting ready for ski season, where you back up against a wall, put your back against the wall and slide down so that your knees are bent about 45 degrees, and then hold that and do sets of sustained wall sits. And after about 10 seconds, you start to feel the burn. But because it's not a pounding exercise, it's generally fairly well tolerated, a good way to train. I wouldn't go to the gym and do the quad extension machine. That tends to make knee problems worse. So that'd be the one to avoid.
I have a question regarding the scar tissue that builds up. My husband had a knee replacement and then 7 months later had to be taken out because of extensive staph. They of course put a spacer in to hold it while they got rid of the staph, which took quite a while. Eventually had the knee put back in, so that was 3 surgeries on that knee. He did go to physical therapy, and he's the guy who's in the gym 5 days a week anyway. He cannot bend that knee. That was in 2008, 2009. He just cannot bend that knee. Is he ever going to be able to break that down, or is that something at this date that's going to have to be cut out or left alone?
Unfortunately, it's probably going to have to be left alone. With multiple surgeries and revision surgeries, which you're describing, with each procedure, more scar tissue is there. And even if you remove scar tissue, more will form. And what she was describing, unfortunately, was an infection where he was treated for a long time, where he was not moving for extended periods of time. And so when that happens, you can lose your knee motion. So that's an unusual event, but it's unfortunate. There's no easy solution for that.
I have a full knee replacement in my right leg. And recently, since 10 years, great, works great, nothing wrong. But recently I passed out and I landed on my knee. So there is no pain and nothing, works fine, but twice during the night I woke up and it was twisted with a blanket and it hurt. And it did really hurt. And I tried to roll back slowly, carefully, and then it said, knack, everything was gone. Should I worry? 10 years.
Let me just take that. Let me ask a question. When was the last time you had an x-ray of your knee?
Well, probably 10 years ago.
10 years, okay. So this brings, that's kind of what I thought. So the recommended follow-up after joint replacement, we see patients at 1 year and then every other year after that forever. Because things can go wrong and patients can fall and do things, or things can come up, and then changes in recommendations regarding antibiotic prophylaxis before dental work, those change. And so it's our opportunity to continue to educate our patients. So my recommendation is that you get an x-ray of your knee, because things can go wacky. And if you land on your knee, you can crack your kneecap, you can loosen something, maybe not something acutely, but maybe something came a little bit loose, and then you're rolling around at night and then something else is out of place. And a lot of things you can diagnose by x-ray. Implant loosening you can diagnose very well by x-ray. And a physical exam, moving your knee around, the surgeon can identify a lot of other things that you can't see on x-ray. So I'd recommend you have your knee evaluated.
I never heard that before.
Yeah. Yeah. Time to go in and see somebody.
Hi. I've been doing physical therapy for a few weeks, and it's been really painful doing the physical therapy. And I've read in a physical therapy book that we shouldn't do anything if it causes real pain. And they keep telling me at the physical therapy place, just ignore the pain. You've got to strengthen the muscle. And I feel a lot of times like I just can't do it. It's just too painful. And, so what do you think about that?
Unfortunately, the motto, no pain, no gain, doesn't always apply. And so especially with things with arthritis like you're talking about, or if your back's involved or other things, there will be a point where it may cause you more pain than do good. And so it's another opportunity there for the therapist to listen to the patient. You know, just it probably won't cause permanent structural damage, but it may cause you to limp longer, be in longer pain, or other things like that. So in the end, you might be going more backwards than forwards.
You have to remember that muscles cross the joints, and when you use a muscle, you're going to be loading the joint. Dr. Saw was talking about the forces that are on joints when you get out of a chair and things like that. When you use a muscle that crosses the joint, it loads the joint. So a therapist, if they're trying to strengthen you and you have an arthritic hip and they have you doing an exercise to strengthen a muscle that crosses the hip joint, it loads the hip joint. And so that's why if a patient preoperatively asks me, should I go to physical therapy to prepare for my operation? My answer is no. I tell them to get on a stationary bike, do things that they can tolerate, do something, but to have a therapist go after it, I don't think is the right thing. Our physical therapists here are excellent at rehabbing our post-operative joint replacement patients, but I don't recommend physical therapy for treating the arthritis patient preoperatively.
Okay, we have one more question.
Approximately how much time would it take before one could drive an automobile after having one knee worked on or operated on?
Depending if it's your right knee or your left knee, obviously. Yeah, so if it's your left knee, and depending on what kind of pain medicine you're taking, so obviously you don't want you driving if you're taking a lot of pain medicine that's altering your reflexes, but it's quite common for us to have patients who are driving at 2.5, 3 weeks. So much faster than it used to be, just because they regain their strength in their leg and are able to do what they need to do to hit that break in time. So people are out and about much quicker.
All right, and that'll conclude our seminar today. Thank you so much. One more round of applause.